Good morning, everyone, and welcome for the session on controversies in medical retina. I invite my co-chair, Timothy Lai, and Dr. Shruti Arepalli, if you're present, to join.
Thank you. Not this one.
No, this is the session.
Okay.
Wrong session update. Due to clashing commitments, we have a slight alteration in the session order. May I request Dr. Tara Prasad Das to make his presentation on challenges to manage retinal diseases in India.
They may need to switch to presentation.
Oh, there I go. Good morning. Thanks, Mona, for accommodating me. Welcome, team and friends, to APO AIOS Delhi.
Sir, are your slides up?
Okay,
Dr.
my
Tara
slides
Prasad
coming
Das'
here.
slides.
Slides are here, but not there, though. It is here, but not there. Thank you. When I designed this session with Mona and Neil Bressler, one interesting idea came out that how do you really manage retinal disease, because in Asia Pacific region, China and India are the larger countries, so the larger burden. So we said, let's look at it. Are you really prepared or not prepared? How do you look at India? India is 29 states and 8 union territories with a 1.4 billion people habitating in a over 3,800 square kilometers and with a population density of 488 per square kilometer. We are 36% or 37% urban and little less than 50% are female population. Good part is that we are the fifth largest economy of the world with 3.5 trillion US dollar economy. We had a world share of 3.5% or so. Our GDP growth is 8% and per capita GDP is 2481 US dollars. But when I look at this burden of blindness in India, I look at it two different ways. One, what is the country-specific blindness, India-specific blindness, and then India being a large country from Kashmir to down south to Kanyakumari. I look at that economic transition level of, because India is not actually one state, it is a larger federation of 29 states and 8 union territories. How to define ETL, epidemiological transition level? It is a all age disability adjusted life years over the communicable maternal neonatal nutritional diseases. We will divide them. Low ETL is bad, high ETL is better. High ETL means higher non-communicable diseases and higher proportion of injury. And lower ETL means higher communicable diseases and lower burden of injury. We divide the country by that way. And before they talk about the Delhi stands for the measure of number of years lived with health or with disease, and we compare that and we find out how people are living early and dying early. The prevalence of blindness over last decade, as measured in India by large epidemiological studies in 2010 and 2019, the good part is that both visual impairment and blindness reduced by nearly half time, from 5.3 to 2.5 of visual impairment and 0.68 to 0.36 of prevalence of blindness. And how to define that? We define as blindness as just like WHO less than 2400, and visual impairment divided into severe, moderate, and early visual impairment. Also important, look at the functional low vision, which is visual acuity of 20/60 to light perception with the visual field of less than 10 degree. Very important for navigational, for quality of life. But divide that also into by gender, we find that in any segment of the blindness or visual impairment, all segment of visual impairment, female gender have a higher burden of blindness, visual impairment than the male gender. Then divided at the ETL, economical transition, epidemiological transition zone, if you divide into the color coded here, green is high and the blue and cyan is middle and the red is low. And the whole country is not one transition zone. So based on that, you find out that blindness and visual impairment profiles are different. Example, in high ATL states, down south in Karnataka and over here, if pointer goes, yes. In the Kerala and Tamil Nadu example, high ATL, there are blindness profile is 1.43% compared to low ATL, which is over 1.74%. So when you look at the visual impairment, similarly, high ATL has got a comparatively lower visual impairment than the higher ATL states in the country. So 6 key factors in retinal care in India, I look at it, the complexities of care, the disease prevalence, geographic distribution in the country, patient volume, health infrastructure, and the training and expertise of the people. All retina care requires a specialized care. Whether it's a diagnostic, obviously it is more expensive than other diseases, but surgery requires higher skills, that means higher training. Look at the disease prevalence, and this is what it shows the national average. Compared to national average, the blindness or visual impairment is much higher, 21.4 times higher with blindness and retinal diseases in India compared to the national average, of which includes cataract, refractive error, etc. Similarly, on the refractive error. I've taken diabetes as a model to find out how they distribute in the country. We find that they are not evenly distributed. There's some states are low, some states are high. Example, high ATL states like Kerala and Tamil Nadu, higher blindness, diabetes prevalence compared to this. Not only that, we look at the urban and rural, they're also different. That means at least prevalence of diabetes is different in the country, both in rural and urban area between the high and low ATL states. Look at this, people over 50 in India between the census of 2019, 2021, 138 million. We look at translated into actual number, there are 24.86 million people who are blind or visually impaired of retinal diseases, and of which 43% are blind and remaining are visually impaired. There are 15, as of the last count of a couple of months ago, it was 1,500 retina specialists in the country registered in our society, Veteran Society India. If you divide them into 285 working days, removing all the Sundays and holidays, then the burden of DR, AMD calculator and other diseases requires 70 people a day you would examine, 58 for a direct care and 12 for review patients. If you look at the distribution of the care in India, obviously in all specialties, the private service is little better off. 65% care in India is given by the private organizations, and remaining by the public health services. Somehow other public services are not as efficient as private services right now in the country, at least for diabetic retinopathy care. If you divide those areas into availability of retina specialists divided by the ETL is shown here, but this will be a little confusing slide to calculate, we don't want to calculate it. But then one example, a small state like high ETL of Kerala has got 78 people, and the larger ones like this have got a comparatively less number of people. I divide that into the number of people available. The ideal in the world by WHO standard is it should be 10 retina specialists per million people. Doesn't matter whether high or low ATL in India, there are less people, and obviously higher in the higher ATL states compared to lower ATL states. So 5 solutions, from capacity building to policy change. Let's look at the capacity building. Years ago, 2015, I was working with IAPV. We had a meeting in Nepal to find out what is the world or Southeast Asia ready for take care of the sustainable development goals. At that time, we said that capacity building, human resource for eye health distribution, eye health, and then poverty alleviation, 3 important requirements in 2015. That has not changed in 2020 when you publish again. Then we said that investment in a structured eye care delivery is very important, so to improve the workforce, as applicable to most part of Southeast Asia, so also for India. That is why WHO came out with a system how to engage from the community to tertiary care, and they call it integrated people-centered eye care. And where we can suggest for retina care, at least we can talk about. Can I continue for a couple of minutes?
Continue.
How to do advocacy in the community level from general ophthalmology to a specialist ophthalmology, retina specialist in the country. So supposing we have this actual number, we had a 1.38 million general physicians and 2,800 general ophthalmologists. If you engage them for fundus screening for general ophthalmologists So general physicians and 28,000 people for laser or intravitreal injection, then the requirement is that less than one person of diabetes at least have to examine a day for the fundus photography, and around 3 people who do an injection or laser. Much easier compared to taking care only retina specialists. So my recommendation has been always that this thing can be done by somebody else. Retina surgeons can do surgery or higher things. Luckily, technology developing in India, we have both table-mounted and handheld small portable fundus camera, which can take photographs in non-mediatic fundus cameras. That is has a huge, good amount of sensitivity, specificity, and negative predictive values. So we have published many times, and so also for the AMD. Last few months ago, the government of Kerala for the first time in India actually had a huge policy change that it launched actually a non-mediatic camera from the community to the tertiary level so that at least diabetes and AMD can be taken care of. This supposing other states of India start copying this idea, then most probably a huge policy change for the country to handle all the retinal problems. So problems are high prevalence, low human resource for eye health, unequal distribution, high cost of care because of growing population, aging population, and lifestyle changes, increasing urbanization. But the solution also lies that task shifting, task sharing, use of new technology, including artificial intelligence, and adapting the newer model of health delivery like universal health system, health policy change, reduce cost of care and advocacy. Thank you very much.
Thank you, Dr. Das.
Since I have to go, Muna, any question, then I will have to answer now because I have to run to another, another place.
Since the talks are very different, we'll be having a couple of questions after each talk. So does anyone have any question for Dr. Das? Otherwise, I have a question bar comment. Anyone has a question?
Okay.
Dr. Das,
I was clear. Okay, no,
I have a question for you. We always talk about the burden for the doctors in diabetic retinopathy screening, and I've always noticed we say, but doctors really don't seem to be that busy. The question is the patient sent or not? Because if the question is, does the patient actually come to the doctor? It's not that the doctor is so busy.
That is why the integrated people center care, you go to the community is important. Yes. Supposing community do advocacy that you have to go to a doctor, and then that they climb up to the primary to secondary level, then most probably will happen. It doesn't happen in all this. Example, Kerala, everybody goes to the doctor, not happen every. So we require a lot of advocacy, but then also we, the retina specialists all sitting here, must shun away the idea that only we have to treat everybody. And don't have to treat everybody. Example, how many ophthalmologists today actually do a refraction? It was once upon a time, it was bread and butter. Similarly, we have to think an idea that how do we distribute people, because with 101 million people diabetes in the country, 136 million undiagnosed diabetes, 236 million. So how do you handle this? So I think it's a question of time when we'll go to doctor. Supposing like we have done that, go to the, instead of building a large tertiary hospital, go to a secondary, primary hospital, then go closer to people. Most probably this is possible, maybe in next 10 years' time.
Yeah, and probably just one line from the person who prescribes the medicine to the patient for diabetes, go see an eye doctor. So that itself transfers a little bit of responsibility for patient to find. Thank you, sir.
So am I allowed to run away?
Yes, thank you so much.
Okay, thank you, Dr. Das. So the next talk will be a pre-recorded talk by Dr. Paichen Xiao from China. The its topic is potential hazards of low-level red light therapy in myopia. You can play the video. Thank you.
From Shanghai, China. I'm honored to be invited today to share my topic on the potential hazards of low-level red light therapy in myopia. There is no conflicts of interest. Myopia has been a huge burden in Asia, especially in East Asia. It is predicted that by 2015 there will be about 5 billion people with myopia and 1 billion people with high myopia. Myopia brings further vision challenges because high myopia increases the risk of pathologic ocular changes such as cataract, glaucoma, retinal detachment, and myopic macular degeneration, all of which can cause irreversible vision loss. The situation is very serious. Parents Patients and doctors are very concerned. We want to prevent the development of myopia and to slow its progression. Of the many strategies, repeated low-level red light (ILRL) has emerged as a popular yet controversial option. For the past 3 decades, ILRL therapy has been used in China as an alternative treatment for amblyopia, despite the lack of conclusive evidence of its efficacy. In recent years, IL has been repurposed as a novel approach for myopia treatment and has seen increasing use across the population. There are more than 10 commercial brands of ILRL devices commercially available in China. ILRL therapy directly exposes the eye to a laser with a wavelength of 613 to 650 nanometers. The 3 minutes exposure is scheduled twice a day at an interval of at least 4 hours every day, or on weekdays for at least 6 months. Its mechanism remains unknown. It may prevent axial length elongation through thickening the choroid and increasing the choroidal circulation. There are international standards regulating the classification, hazard, and safety controls for laser products. Class 1 lasers are low-powered devices that are considered safe from potential hazards. Class 2 laser products are described as low power, less than 1 milliwatt, visible light lasers that could possibly cause damage to the eyes. Class 2 devices require additional controls to ensure their safety and effectiveness, but the clinical trials are not strictly mandated. As for laser products with laser power of 1 to 5 milliwatt, they should be classified as class 3 and should not be aimed at an individual's eye. Published studies using ILRL therapy reported that the devices are class 1 or class 2 laser products. For example, the light power entering a 4 millimeter pupil of this device is supposed to be about 0.29 milliwatt. Then it is classified as class 1, which is at a level considered safe for direct ocular exposure that would not create retinal thermal hazard. There were several well-designed randomized controlled trials in China that showed this effect for myopia control. This clinical trial was published in JAMA Network Open in 2023. The primary outcome was the incidence rate of myopia at 1 year follow-up. The ILRL intervention significantly reduced the myopic shifts in terms of axial length and SER. For patients with high myopia, the ILRL also demonstrated stronger treatment efficacy, with half of the participants experiencing substantial axial shortening. Due to the widespread use of ILRL for myopia in the market and hospitals in China, a Chinese expert consensus was introduced in 2022 to regulate the application of ILRL therapy. However, we have seen 2 cases of retinal damage after ILRL therapy. Case 1, a 12-year-old female presented with bilateral vision loss for 2 weeks after 5 months application of ILRL laser exposure for bilateral moderate myopia. The patient complained of abnormally bright light 1 month ago, and after images prolonged after exposure. OCT image before ILRL therapy were normal. The BCVA declined from 20 to 20 to 20 to 30 in each eye. Fundus photographs revealed only bilaterally darkened fluid with a hypoautofluorescent plaque in autofluorescence images. After discontinuing ILRL therapy for 3 months, in case 1, partial restoration of retinal structure was observed, along with a visual improvement to 20 to 25 in both eyes. Case 2 was a 5-year-old male presented with myelinated retinal nerve fiber and myopia of minus 8 diopters in his left eye, seeking methods to control the myopia. During the last 10 months, besides RGP, ILRL was taken for the left eye. Its visual acuity was 20 to 40. OCT images revealed shallow parafoveal retinal detachment and discontinuity of the ellipsoid zone and the interdigitation zone in the left eye. Genome sequencing did not detect suspicious inherited retinal disease-related gene mutation. After 15 months without ILRL, OCT images showed a brokenly continuous ellipsoid zone and a partially absorbed subretinal fluid. BCVA improved to 20 to 33 in his left eye. These two cases demonstrated the potential hazards of ILR to the retina and needed to be taken seriously. Potential mechanisms of retinal damage may be explained as follows. Light with wavelengths ranging from 400 to 1,400 nanometer can reach the retina, posing a potential hazard. The IRIL therapy emits 613 to 615 nanometer laser, so it can reach the retina. Some ocular microstructural changes have also been discovered in clinical studies. This study reported that IRIL prevents myopia progression and improves the macular function by examining FERG and contrast sensitivity. However, on OCT, the REZR increased significantly at 6 months. The RPUSR increased significantly at 6 and 12 months, and the increase in RPUSR was greater with greater axial length regression. We are concerned whether prolonged overaccumulation of PUS damages photoreceptors and RP cells. Therefore, further studies are needed to determine whether RPUSR can be restored after discontinuing ILRL, and the changes in RPUSR and the structure and the function of photoreceptors and RP cells over longer use of ILRL. This study showed choroidal sinking intruded after ILRL treatment, especially at the subfoveal sector. Another study showed that there was a time-dependent stimulative response in choroidal and retinal circulation. These findings may contribute to axial length shortening. But is the retina and the choroid being heated? These questions remain safety concerns. Moreover, a 2-year post-trial follow-up study of the first clinical trials reported sustained and rebound effect of ILRL. Continued ILRL therapy sustained promising efficacy and safety in slowing myopia progression over 2 years. However, the long-term safety and efficacy of ILRL treatment are still in doubt. So far, the place of laser product management has been changed due to safety concerns. These laser products for myopia treatment were no longer allowed for production and sale. From July 2024, they were classified as Class 3 medical devices, which should not be applied unless their efficacy and safety were fully proven. We should be the first ones to embrace new technology, but also we should be the first to be hesitant about the side effects. To include, many clinical trials and experimental research in China showed that ILR can effectively prevent myopia and slow its progression. However, non-clinical trials reported results longer than 12 months and no long-term safety data available. It may expose the retina to high toxicity. Thank you.
Well, so unfortunately, Dr. Xiao cannot make it to the meeting, and there's no facility for online questioning. But I'll be happy to comment on this technology. So apparently it's not available in India at the moment, yeah. So in Hong Kong, we're doing some clinical trials. China is getting more popular, yeah, any comment or question?
I think for me, the interesting thing was the rebound that happens after cessation of treatment. So long-term following these patients, do they go back to their original baseline completely? So you need it
Yeah, so it's quite similar to other treatments as well. With we are using a lot of low dose atropine, and once you stop it too early, it will rebound. So that's why a lot of patients are still on low dose atropine to prevent the myopia progression. Okay, so let's move on to the next talk, please.
Yeah. Does anyone in the audience have a comment? Or I think the most experienced probably is Timothy among the three of us sitting here. So.
But yeah, although it's effective in the clinical trials, but as mentioned by Pai Zhao, I think the long-term safety is definitely an issue. So these devices, if they tune the laser too powerful, it's of course very prone to damaging the retina.
Okay. So next we'll welcome Dr. Ta-Kan Lim, who will be speaking on randomized controlled trial results versus real-world management of neovascular AMD in Asia.
Thank you very much, Chairman. I'd like to thank the organizer for inviting me to share a few points on challenges of real-world management of wet AMD despite the very good RCT results. This is my conflict of interest. So randomized controlled trial are based on well-defined patient population, well-defined treatment posology, strict patient adherence, but with limited trial duration, usually up to 2 years. In real-world management, we oftentimes have diagnostic challenges, double or triple pathologies, subtypes of wet AMD we have to work on. There are variations in posology and challenges in following up the patient, and we have patients with lifelong treatment. So take, for example, this type of VA curve, which is familiar to all of us. We see very good visual improvement in the first 3 months, followed by a stabilization phase, which lasts about 1 to 2 years. We've seen in all the agents that we know of today, but the real-world outcome is not as rosy. In Luminous study, the real-world outcome is increase of 3 letters from a base of 52 ETDRS letters. Now, why so? There are at least 5 reasons why we could not achieve the good result of RCT, and these the real-world challenges that I'd like to highlight with the use of a few case examples. First, diagnosis. In Asia, pachychoroid is very common. This is a patient that's referred in after 4 aflibercept injection, but to no avail. You can see that this patient was treated for pachychoroid neovasculopathy because of the double layer sign. Now, we repeated the OCT angiogram, did not show a CNV. ICG did show a CSCR pattern and confirmed with the FA. So the good old single spot focal laser solve it. The second is the subtypes of wet AMD in Asia. As you know, about 30 to 40% of our wet AMD are polypoidal patients. Planet study has told us that anti-VEGF work very well for polypoidal patients. And in fact, Xalwin is now showing even better polyp closure rate of about 51% at 3 months. And Planet showed that aflibercept 2 milligram can close polyps of about 33% at 2 years and inactivate polyp of the 80%. So many of our patients are treated with anti-VEGF treatment today. Now, this is one example of pachychoroid neovasculopathy observed for 2 years and then turned exudative. You can see subretinal fluid there. And there is ICG proven PCV. This patient was treated with aflibercept, and 1 month after injection, voila, the subretinal fluid goes away. And we are about to celebrate at 3 months. However, after 7 aflibercept injections later, we could not extend the patient beyond 2 months. So at this point, the patient got very upset with me, and he wanted to stop injection. Now, this is the patient has got 2 stents in the heart and on double anticoagulation. So this is one patient that I really cannot leave an open polyp in the eye. So I bargained with him, said, give me one last chance. I'm going to do one treatment for you, and after that, we'll stop and watch. And this is the patient 1 month later after combination therapy with verteporfin and injection. Now, that brings to the point of AIOS study that shows that combination therapy can close polyp at a high percentage and return better visual outcome compared to ranibizumab monotherapy. Now, this is one such patient enrolled in this study. You can see that this patient, after treatment, actually had quiescence for at least 6 years, and then at this point, 9 years later, without any injection, this patient suffered recurrence, and you can see that there are 2 polypoidal lesions out there. So if you don't throw away your ICG, you can identify where the troublemakers. You can do just low-cost focal thermal laser photocoagulation, and this patient is back on the quiescence for another further 2 years. So imagine this is 10 over years without single injection. So which are the patients that we need to select for PDT combination, and which are the one we go for anti-VEGF? I think currently many of us will start with anti-VEGF, and for those who are persistent, we go on to PDT. But notice in every study, the polypoidal size is actually twice of planet study. And therefore, for a larger polypoidal lesion, you may think about combination therapy first if you have access to the ICG and the verteporfin. Now, the other big problem is adherence. You can see that although in the well-funded study, well-funded countries, patients actually did not get the same RCT result as you would expect, and that's probably because of adherence. So other than dissatisfaction with VA outcome, financial burden is huge. And in Asia, if you look at the GDP map, you know that anti-VEGF therapy only benefit a small proportion of patients in Asia. Biosimilars are here, but they are not cheap either. But there are other factors, for example, difficulty to access booking appointments. If you've earlier heard Dr. Prasad mention about the percentage of ophthalmologists per million population, and in Asia, the number is far lower than Western countries. And there are patients also having injection fatigue, even if they have the financial means and have the access to ophthalmologists. Many patients end up with tiredness of continuation of treatment. This is where new long-acting agents such as faricimab and aflibercept 8 mg hold promise, because you can achieve the injection interval of 3 to 4 months in about 60 to 80% of patients, which means the patient only get to come back for about 3 to 4 injections per year at fairly fixed interval. Now, the last to discuss about the challenge is long-term outcome. You may get very good result in the first 2 years, but going on, studies after studies has shown that vision start to drop back to baseline and then go into negative territory beyond 4 years. And one such condition is paradoxical response, which you would see in about 4% of your patients, especially those long treatment patients. Now, the other problem is GA. You can see the GA appearing in front of your eyes, as shown in these scans. So, in summary, there are several challenges and there are several ways we can tackle them. But if we hold on to patients with good rapport, I think we can overcome much of these challenges. Thank you very much.
Thank you. That was excellent. We'll open up to the audience. Does anyone have any questions?
On the back.
Sure.
I think there's a mic in front. There's a
There might
mic
be.
in front, yeah, please. I think there's a mic behind the cameraman as well. Yeah.
given the poor affordability of patients in India and in Asia, as you speak in general, I'm just curious. You're talking about Eylea so consistently in your talk. What is the first injection that you recommend to patients when they come into your private practice? Let's say the patient is coming for the first time and he has wet CNVM or first episode of wet CNVM. So, what will be the first injection that you're recommending in your practice generally? I just want to know that.
Yeah, I think the first anti-VEGF you will inject varies widely based on the country's funding, especially for patients that needed public funding assistance. Different countries have different sort of level of subsidy for different type of agent. In our country and in our practice, the standard drug we use is ranibizumab as a first instance. Then thereafter, we will go on to a scheme called Medical Assistance Fund, for which faricimab is now approved under this funding. And then we have MAF plus, which is aflibercept 2 milligram, 8 milligram. These are under MAF plus. So this is the sequence we use. Yeah.
Thank you.
Thank you.
Thank you. And if there are no other questions, it gives me great pleasure to introduce my co-chair, Dr. Timothy Lai, who will also talk to us on a subject that's in a little bit of controversy now because we are detecting it more and more often, non-exudative choroidal neovascularization.
Okay, good morning everyone, and thank you Muna for the invitation, and it's my pleasure to come back to India and talk about today it's on, this session is actually on controversies of medical retina, and I'm talking on non-exudative CNV. So these are my disclosures. So what's non-exudative CNV? So this is a CNV that grows into the subretinal RP space without any leakage of fluid or blood. So you can see healthy retina on the top, and in the non-exudative stage, you only get the elevation of the RP slightly because of the CNV growth, but there's no subretinal fluid on top. So these cases are usually asymptomatic without causing a visual loss, but it has the potential to progress into the exudative form, which can cause visual impairment. It's mostly associated with AMD, but can also be associated with other diseases like CSC, PCV. These are pachychoroid diseases, android streaks, hereditary retinal dystrophies, ocular inflammation, or uveitis. So these are some examples. So here you can see on top, there's a patient with RP. You can see the diffuse reduced autofluorescence in the fundus autofluorescence. On top, you can see a CME associated with it. In the bottom, you can see FA didn't show a leak, but the OCT showed this lesion, a CNV lesion, which didn't have any exudation before, back in 2017, and then 2 years later, it started to exudation. These are some examples in pachychoroid CSC condition. You can see the top ones are those with subretinal fluid. So these are pachychoroid neovascularization with leakage. In the bottom, you can see these basically the non-exudative CNVs. Here's a case of ocular inflammation. You can see some scar with the OCT showing the CNV, but without any exudation. So what are the controversies for this topic? So firstly, the nomenclature. So how should we term these lesions? So these CNV has actually been described for a long time. So back in the 1970s, it's been shown in the histology of these postmortem eye with the AMD, which actually had a CNV but without any exudation. So should these be called subclinical CNV, quiescent CNV, or non-exudative MNV? So the Conan study group, this is the nomenclature study group, say they recognize this non-exudative MNVs as a distinct clinical entity, but it did not reach a consensus for further subtyping. So they actually suggested to discontinue the term quiescent because we really do not know the cutoff time required to determine whether this is a new CNV versus a mature CNV which is not leaking. Second controversy is the pathophysiology. So exactly why these develop is unclear. So there are two hypotheses. So the first one is that you get this stable non-exudative MNV, which can reduce the progression rate of the RP atrophy. This may provide some nutritional support to the overlying RP or photoreceptors, and this is actually supported by the histological features of these lesions, which is quite similar to the normal choroid capillaris. The second hypothesis is that these are actually CNV which developed and develop and represent regressed new vessel as seen in the experimentally induced CNV lesions with or without leakage. So there are some good papers. For example, there's a very nice paper from Armani Fossi's group. They looked at these patients' progression of the subclinical or non-exudative CNV, the baseline, and follow these patients and compare the rate of GA growth with or without subclinical CNV. And you can see that with those patients without the subclinical CNV, they actually had progression of GA a bit faster. But a few years down the road, Phil Rosenfeld, they did another study. They looked at 9 eyes with geographic atrophy and the non-exudative MNVs and followed for at least 1 year, and they measured the growth of both the MNV and the geographic atrophy growth rate. And they actually did some correlation analysis, and only 1 eye showed a significant but rather weak correlation between the GA growth rate and the MNV. So they actually concluded that the results are not consistent with having a non-exudative type 1 MNV having a strong inhibitory effect on the local growth rate of the GA. Third controversies are the diagnosis of non-exudative CNV. So these, traditionally we use FA as the gold standard of defining a CNV, but they do not leak because they are not exudating. So that's why we cannot use fluorescein angiography to diagnose them. So another choice is to use the ICGA, which actually can show the plaque in the late phase, but it's not widely performed, so the exact accuracy is not clear. OCT is actually very popular, so every retina specialist is using it, and you can see these non-exudative CNV as slightly elevated RPA detachment, or also called SHRI, which is shallow irregular RPA elevation, and this is defined by having a double layer sign with a non-homogeneous internal reflectivity, and the RPA elevation has to be at least 1,000 micron in length and also less than 100 micron in height. So some of these smaller CNV, however, if they are less than 1,000 microns, you might not be able to detect it with this definition. So here's an example. So you can see elevation of Brooks membrane, and then you can see RP is slightly elevated, and you can see double layer sign with the MAB in between. So OCTA show it quite well. So that's why OCTA is now the investigation of choice for these cases. You can detect the flow signal of the blood particles inside the blood vessels, but there are potential issues with the artifacts and also potential rate affected by the protocol into the scan time. So sometimes the flow inside the non-exudative CNV is very low, so you might not be able to pick it up with the OCTA. Another controversy is the treatment. So how should we treat these patients? So if you look at the literature review, so the natural history of these cases, they generally progress not too quickly, but still a substantial proportion. So here, patients were followed for 6 to 12 months. You can see a rate from 6% progressing from the subclinical or non-exudative CNV to exudative type, about 25%. So about up to a quarter of them can progress within 6 to 12 months. And if you look at another longitudinal study, you can see these patients, 6 of the 53 eyes without any CNV, they changed from dry type to the wet AMD or exudative CNV. But in those already with a non-exudative CNV, 80%, 8 out of the 10 eyes developed the exudation. So there's an 18-fold increase rate of exudation. So here are some examples with progression on the left side. They did the OCTA every 2 months, and at the 8th month follow-up, you can see exudation started to develop. Left side also initially didn't have any MNV, and then baseline you can see this lesion, and then 4 months later developed the exudation. So one strategy is to use anti-VEGF, regular injection to prevent them, or the other, it's to just basically observe them and treat them with if there's exudation. So Clement Chan actually performed such study called the PREVENT study in the States, and they looked at the use of prophylactic ranibizumab treatment every 3 months compared with sham injection in these patients with non-exudative AMD. So these patients actually, if you injected them, they show there's no difference in the conversion from dry to wet AMD. So in about 8% of eyes still develop this subclinical CNV regardless of whether in a sham or the ranibizumab treatment. So prophylactic treatment is probably not useful. Some further directions, so we can consider using AI to help us to detect these lesions. So you can see these lesions are very small and you have to go through the scan one by one, which is quite time consuming. And with artificial intelligence, they actually achieve very good results comparable with expert graders. And you can also use the deep learning AI models to see whether some of the lesions are high risk or not. And by combining the OCT and OCTA findings, they actually perform better than human performance. And now currently a prospective study is being conducted in UK NHS. They will look at 800 patients with new onset neovascular AMD in first eye, and then look at the prevalence of these non-exudative AMD in the fellow eye and the rate of conversion. So to conclude, so non-exudative CNV is a distinct clinical entity in AMD and many other retinal conditions. Multimodal imaging, especially OCTA, is very useful for diagnosing them. Though these patients should be monitored regularly and treated with anti-VEGF when signs of exudation start to develop. And in the future, artificial intelligence with deep learning is going to be useful for us to diagnose these cases as well as predicting the early activation of the lesion. Thank you very much.
Thank you, Dr. Lai, for a very insightful talk. Are there any questions from the audience? Yes, Dr. Lai.
Fabulous talk, team. May I know, is there a recommended follow-up interval for these patients with non-exudative AMD?
Thank you very much, Dr. Hang. So you really don't know when they occur, when they develop. So I would recommend maybe every 3 to 4 months. Some people say 2 months, but maybe that will overburden ourselves. So I think 3 to 4 months, up to at most 6 months. But it also depends on the fellow eye status. If the fellow eye already has a scar or having regular injection, these patients would need to come in anyway. So then these patients can be followed a bit closer. Thank you.
I have a question on the idea of treating versus observing. I think all of us now decide to observe these patients. Would your threshold be different if the other eye has been lost due to advanced neovascular AMD?
I think I would still monitor, but more closely. So as soon as they develop new symptom, then I'll start treatment and ask them just come in, call my clinic immediately. And then also every time they come in, I also examine the fellow eye because they will be coming in for example, T&E treatment for the fellow eye. And then I would definitely scan and look for any non-exudative CNV or any signs of exudation in the not affected eye.
And do you have any branching patterns or algorithm to tell you whether this disease will progress or it will remain quiescent?
Sorry, I can't hear you.
Do you have any AI-based algorithms available in the market?
Okay, thank you very much. Very good question. So AI, they are still doing study at the moment. So not commercially available, but of course, in the future, hopefully we can have some tools which will be useful for retinal specialists.
No, will it predict whether it will progress?
Yes.
Or
Yes, yeah, that's what the last study I mentioned about. So they will look at the features of these MNE, for example, elevation of the Shri, and also the OCTA, what kind of pattern the lesions are, and then that might help you to predict which is going to be leaking sooner or later.
And diagnosis is only based on OCTA, or you diagnose it on OCT also?
OCT and OCTA, I use both. Yeah. Thank you.
Thank you very much. So next we'll be bringing up Dr. Joseph Carroll, who will be discussing adaptive optics, measures of visual acuity in albinism. Thank you, thank you.
Thank you very much. This will be something a little bit different than you've been hearing about, but no conflicts of interest that are relevant to this presentation. I want to acknowledge funding sources that have contributed to the work I'm presenting today.
Okay, sure.
So, as many of you know, albinism is a condition associated with aberrant melanin biosynthesis, and this results in decreased or absent pigmentation in the hair, skin, and/or eyes. Importantly, all forms involve ocular manifestations, such as iris transillumination, macular translucency, photosensitivity, increased refractive errors, nystagmus, and importantly, reduced acuity, although this is highly variable. And the foveal manifestations include absence of a FAZ, loss of the annular reflex, and foveal hypoplasia. And shown here are just capturing those foveal manifestations, where on the left you can see a normal foveal contour, on the right is a patient with oculocutaneous albinism, showing an absence of the majority of foveal specializations. Now, one of the sort of controversies within albinism is understanding the high degree of anatomical variation in the patients. And so to illustrate that, over on the right I show you two OCT images that should look fairly similar to you in terms of the foveal specialization. One of these is from somebody with normal vision, 20/16 acuity, and the other one is from someone with albinism, 20/80 acuity. And so the foveal anatomy, in this case, in our hands early on, didn't seem to be predictive of visual function. But nevertheless, given this wide range of anatomical variation in albinism, there was an interest to in developing prognostic indicators of visual acuity in these patients. And the group in Leicester in the United Kingdom developed a grading scheme shown here on the right, where they grade the severity of foveal hypoplasia from 1, with fairly mild hypoplasia, up to 4, which is the more traditional foveal plana, or complete absence of foveal specializations. And those are listed here in terms of the extrusion of inner plexiform layers, presence or absence of a foveal pit, lengthening of the outer segments, and widening of the outer nuclear layer. But in all cases, it's important to note that they simply remark these as binary, present or absent. And so when you look at this, you see there's fairly good correlation between acuity and the hypoplasia grade. However, it's important to note there's overlap in these grading schemes. Patients with very, very mild hypoplasia can have worse acuity than patients with very severe hypoplasia, and so it's not a great predictive measure. And so we looked for more quantitative grading schemes. And to do this, we went to the foveal cone specialization. Shown on the right is these are histological studies from Anita Hendrickson and colleagues showing the foveal cones increasing in their packing density as a function of development. And on the right is a concomitant elongation or lengthening of the outer segments that happens as a function of development. And these are things that we can now measure with non-invasive retinal imaging. In fact, when you look at the foveal cone specialization in terms of outer segment length, and importantly, we normalize the foveal measure to a parafoveal measure to normalize for overall global differences in retinal thickness. What we see shown in the graph on the bottom right, the black bar is the mean and 2 standard deviations of normal individuals, and all the blue dots are individuals with albinism, and you can see they overlap quite strikingly with normal individuals. So it isn't such that there's just absent or present outer segment elongation. It's quite a remarkable range. And so we sought to incorporate this into a new grading scheme where we looked at the inner retinal layer excavation, the outer segment elongation, as well as the outer nuclear layer thickening at the fovea. And so when we do this, we get slightly better predictive value. Shown on the right in panel A is the predicted visual acuity from the Leicester grading scheme compared to that's observed. And on the right is the quantitative grading scheme where we actually measure all the foveal specializations, and you can see that the predicted values, it improves to a 0.74 R value, and 94.6% of subjects had predicted values within 0.3 log MAR values. But it's still not good enough, and so what I'd like to spend the last few minutes on is discussing why might this be such an imperfect relationship. Why does anatomy and albinism not predict visual acuity with high degree of accuracy? And so you need to return to what limits visual acuity in the first place, and that is the spacing of the foveal cones. And so this is an image of a patient with albinism taken with adaptive optics. Each one of the circles there is an individual cone photoreceptor at the central fovea. And if this is the limitation on visual acuity is due to the fact that foveal cones normally are connected via a private line or one-to-one circuitry to the brain, such that every cone is acting like an independent pixel, if you will. And so I've shown a Snellen letter E transposed overlying the array of cone photoreceptors, and you can see that in order to resolve that as an E, you would have to have exactly one cone photoreceptor per bar in this diagram, okay? So in this sense, the spacing predicts acuity. Importantly, in albinism, we see that foveal cone density, as I already showed you with outer segment lengthening, is highly variable, but we still see fairly normal packing topography. Here in this image, you can see at the bottom right-hand corner is the foveal center, and as you move away towards the top left-hand corner of the image, the cones get larger and more coarsely spaced. This is a normal cone packing that we would see. And so there's really two possibilities. One, we could retain the intact private line circuitry such that whatever cone density the patient with albinism happens to have, the acuity that we are able to measure in their eye would match the predictions from the cone spacing. Alternatively, they could have altered circuitry between their foveal cones and their downstream retinal circuits. In this case, acuity would be worse than that predicted from cone spacing. So what we did is we took images from patients with albinism and normal individuals, mapped their entire foveal ROI, counted all of the photoreceptors, and developed spacing maps shown on the right, where we can extract estimates of predicted acuity based on any one number of a factor, but we could take the minimum spacing, which would be the theoretical best acuity that this retina could achieve, assuming everything is intact with respect to private line circuitry. We then use our adaptive optics device not to image the retina, well, it also takes a picture, but to deliver a stimulus to the retina. In this case, it's a negative stimulus. This isn't a photoshopped E. This is actually the E that's landing on the retina, bypassing all the optical imperfections. And so then we can actually do psychophysical experiments to measure the adaptive optics corrected acuity, not clinical BCVA. We do this with standard psychophysics. We have 2 randomly interleaved staircases. We run approximately 30 trials per session across those 2 staircases, and then we can generate psychometric functions and estimate the acuity threshold for every single retina that we're studying, and then compare that to the predicted acuity measurements from the direct images of the photoreceptors. What I'm showing you here is our currently unpublished results, but the dotted black line there would be a perfect one-to-one relationship where the predicted measures from cone spacing match what we measure with the adaptive optics. The solid blue circles are from normal individuals. You can see they hover right around the one-to-one line. And then the few orange dots out to the side are our patients with albinism. They have visual acuity that is far below what is predicted by cone spacing, which would be consistent with disrupted retinal circuitry in these patients. Interestingly, the 2 open circles happen to be from individuals with hypoplasia due to premature birth, and they are interestingly somewhere between the 2, although that's still a subject of continued study. So what I've shown you is that despite having severe pigment deficits, patients with albinism can have foveal morphology and cone specialization that overlap with what's seen in normally pigmented individuals, and this would suggest at least partially independent developmental mechanisms underlying pit formation and cone specialization. Individuals with albinism have our AO-corrected visual acuity values that are below that predicted by spacing of their foveal cones. And this would be consistent with altered post-receptoral midget pathways, as has been reported in a retina from a patient with hypoplasia and a history of premature birth. That was from Dennis Stacey and colleagues. That was shown in a histological section in recent years. And then future models obviously would need to incorporate measures of nystagmus into any modeling, because that can, of course, degrade visual acuity. And with that, I thank you for your attention, and I'd be happy to take a question.
Thank you, that was fascinating. Does anyone in the audience have any questions?
Joe, very nice talk. May I know whether there are studies looking at retrograde lighting of the photoreceptor from reflected light because these are albinism patients, there would be reflected light
So
coming from behind.
Perhaps whether they have reduced contrast sensitivity and things like that is what you're looking at. There aren't good measures of I'm not aware of any large-scale study of contrast sensitivity in albinism, but I might hypothesize that certainly due to the absence of melanin in the RPE, there would be increased scatter, so that certainly could affect vision in a meaningful way. That's something we should definitely think about. Thank you.
Thank you. So last but not least, we have Dr. Mahesh Shamagam. He's going to talk about inflammatory retinal masquerades. Yep, yeah, I think that's fine. Yep.
Morning and thank you. So let's start with this slide. This is a young child, about 5 years old, had vitritis and had undergone multiple vitrectomies, and this is how the fundus looks like. It looks like some kind of retinal infiltrates, possibly multiple patches of inflammatory retinal pathology. So, but then not all what that looks like retinal inflammations is retinal inflammation, as we can see. This child, when it presented to us, so this is how it presented. So it's under GA. We are just looking at it. The child had undergone 3 vitrectomies and a lensectomy for a diagnosis of endogenous endophthalmitis elsewhere, and they couldn't find anything. So we are just throwing a light there, and you can see those huge big cells floating around in the anterior chamber and multiple deposits on the surface of the iris. A simple AC tap showed that it was retinoblastoma. At the same time, we gave an intravitreal melphalan, and you can see how well the hypopyon is cleared up. So, and this is just immediately post the melphalan. So what is this retinoblastoma presenting differently? This is a diffuse anterior infiltrating retinoblastoma, and once the media cleared, this is how it appeared. So the retinoblastoma seeding onto the retina can mimic retinal infiltrates, can mimic inflammatory infiltrates, and can present with vitreous seeding mimicking vitritis. But the difference is that these cells are larger, and there's no anterior segment inflammation, and careful examination and imaging may show a small peripheral tumor. Diffuse anterior infiltrating retinoblastoma, you don't see a large big tumor with calcium. It could be extremely small tumor in the extremely anterior part, which may not be picked up very well with an ultrasound or an MRI. So we have to very, very carefully look at it and have a high degree of suspicion to suspect this. Let's look at another patient. This was a 65-year-old with loss of vision in both the eyes and had vitreous inflammation. So we resorted to vitrectomy, and post-vitrectomy you can see a frosted branch angiitis with retinal inflammatory signs. You can see, and there are multiple infiltrates all across the retina. You can see that's a frosted branch angiitis involving particularly the superior retinal vessels. And a cytology specimen was also taken during this time. And when we did neuroimaging, we found that the patient had infiltrates in the brain as well. So what are we looking at? We are looking at intraocular lymphoma. So in this particular patient had a CNS lymphoma with involvement of both the eyes, which can mimic retinal infiltrations, retinal inflammatory lesions. So 80% of the primary vitreoretinal lymphomas, where they present primarily with the eye lesion, will go on to develop CNS disease over follow-up. And those with CNS disease, like this patient, 20% of them will develop an eye involvement as well. So whenever we suspect a primary intraocular lymphoma and confirm it with a biopsy, then these patients have to be serially followed up to see if they are developing a neurological disease. But more often they present like this. This is a 68-year-old with bilateral vision loss and has been on treatment for posterior uveitis for 3 years. That's usually the history. The lymphoma is very difficult to diagnose. They will have vitreous cells, secondary retinal detachment, and vasculitis. But usually do a biopsy. So a simple syringe connected to the vitreous cutter is good enough to take a biopsy of the vitreous and then send it for a cytology. And sometimes we may have to aspirate the subretinal infiltrate, like what we're doing here. So surround that lesion with laser photocoagulation, and the subretinal or the deep retinal lesion is aspirated out and sent for cytology as well. In addition to doing a cytology, we can do an AC tap for cytokine profile. The IL-10 is usually increased in retinal lymphoma, So aqueous, and it serves as an aqueous marker for disease activity as well. So IL-10, IL-6 ratio of more than 1, then you would suspect a lymphoma. And OCT can also be helpful in diagnosing a lymphoma. So these are some of the OCT signs of a lymphoma. You will find this discrete pre-RPE nodules, subretinal band. You can see the outer retina being thickened, inner and outer retinal infiltrate, irregular retinal pigment epithelium, and diffuse vitreous cells. When you find them, then you would tend to think that this could be a lymphoma, not just a posterior uveitis. So how do we treat them? We treat them with intravitreal methotrexate or rituximab if it is just a primary intraocular lymphoma. If there is an associated systemic lymphoma or a CNS lymphoma, we treat them with systemic treatment, chemotherapy, external beam radiation therapy, in addition to treating locally as well. So here is another 25-year-old lady who presents with bilateral optic disc involvement and what looks like retinal inflammation involving the posterior pole, and with some amount of tortuosity of the vessels. So is this inflammatory lesion of the retina? Actually, this is how she presented, with bilateral hypopyon. What is different about this hypopyon? You can see there is not much of a conjunctival congestion or a circumcorneal congestion, and this hypopyon has a convex upper border and appears to be composed of larger cells and doesn't shift easily when you make the patient lie down to one side. So a simple AC tap confirmed the diagnosis of a leukemic infiltration of the eye. So they can present, leukemic infiltrates can present like this. So how do we treat them? We treat them with systemic leukemic therapy, and if it doesn't respond, then the eyes may have to be treated with radiation. This is the post-treatment. You can see the infiltrates have resolved, and of course there is optic atrophy in one eye, but both the eyes, the patient is able to see better. On the other hand, this was an 18-year-old on treatment for leukemia, presented with this infiltrates. So the oncologist wanted to know if this was a leukemic infiltrate, because if it is a recurrence of the leukemia, then he wanted to upstage the disease and advise total radiation and bone marrow transplant in this particular patient. So we needed to know if it was indeed a leukemic infiltrate. So we had to resort to a biopsy. So here, despite the patient having a very good vision, you can see the normal macula. We induced a posterior vitreous detachment, then did laser photocoagulation around the infiltrate, and we had to do a biopsy. So a diathermy is done around the lesion to be biopsied. Then with the scissors, the retina is cut, a small localized retinectomy is done. And we enlarge the sclerotomy so that the tissue can come out without macerating it. And using a bimanual technique, we cut that piece of the retina and maybe the underlying choroid and remove it. So this was transferred to the other forceps and removed out of the eye and sent for cytology. Unfortunately, this turned out to be an infective infiltrate rather than a leukemic infiltrate, so the patient did not have to undergo a bone marrow biopsy. This was a 35-year-old lady who presented with something like a retinal inflammatory lesion involving the disc and the peripapillary retina and associated with an inferior temporal branch retinal vein occlusion. So what are we looking at? Actually, this is an optic disc and retinal metastasis from a carcinoma breast. She had actually undergone a bilateral mastectomy many years back. So this is how she presented. She went on to progress like this, having a combined central retinal artery occlusion and vein occlusion, despite the fact that she was on treatment for a metastatic disease. So we had to treat her with intravitreal chemotherapy, and the lesion regressed subsequently, but then of course the vision was lost by the time, and of course she succumbed to the disease in about 3 months' time. So this is a 3-year-old with decreased vision with exotropia, and right eye had count fingers close to vision, and this was the lesion. We're not too sure if it was involving the retina or the choroid, because it was not very cooperative for the OCT as well. And retinoblastoma is something which had to be ruled out as well. So here we went ahead and did a biopsy, because ultimately that is the only way we can get some diagnosis out of this child. So again, a vitrectomy, PVD induction. Then here a retinochoroidal biopsy was done. So initially the retinal tissue was removed and sent for the histopathology, and the underlying choroid was also removed. You can see again a bimanual technique. So this tissue was sent for biopsy because there was a retinal infiltration. But actually this was a very rare diagnosis of a ganglioneuroma of the choroid with retinal invasion. This is a benign tumor. So So treated with transfibular thermotherapy subsequently. On the other hand, this was a 26-year-old lady with bilateral loss of vision of 15 days and had a spontaneous abortion, was suspected to have toxoplasma and treated with toxoplasma treatment, and also with oral oricorazole amoxicillin. So I see this retinal infiltrate continuing to worsen despite the treatment. So a diagnostic and therapeutic vitrectomy was done in both the eyes, but the specimen was negative for fungi and bacteria. So we empirically treated the patient with intravitreal antibiotics and antifungals and oral antifungals as well for about the next 5 months, along with some amount of steroids, and you can see the lesions resolving. Actually, it's an endogenous endophthalmitis because of the spontaneous abortion as well as the intravenous, probably the fluids which were given. Another patient, last patient, 49-year-old, 6 months loss of vision, had this anti-toxo treatment, and it was stopped, and the patient continued to be on systemic steroids. But you can see the toxo titers were still high. So what had happened is the toxo antibiotics was stopped much ahead of what it should be. But on the other hand, the systemic steroids were continued. So the disease presented differently with the persisting retinitis. So we restarted the anti-toxo treatment, and this is how it was post-treatment. So to summarize, neoplastic lesions may mimic inflammatory retinitis, life-threatening systemic malignancies or ocular malignancies. High degree of suspicion and appropriate investigation, including a biopsy, would be required. And infective retinitis may present differently if treated inappropriately. Thank you so much for your kind attention.
Thank you very much for the excellent cases. Any comments or questions from the floor?
Thank you, that was excellent. I had a question about the lymphoma patients that you diagnose. So when we do diagnostic vitrectomies for these lymphoma patients and we find lymphoma in the eye but not in the brain, how do you go about treating them with methotrexate? What is your protocol, and how often do you screen them for CNS disease?
Yeah, one of the things which we need to do before we do the biopsy is to stop the steroids for about 2 weeks, which is something which I forgot to mention, so that we get a better yield. So the treatment schedule is not like the original schedule which is being advised. So here we do a weekly injection for 1 month, then bi-weekly for 1 month, then once a month for the next 10 months. So that's the schedule which I follow. It's either rituximab or methotrexate. I have found some patients not responding to rituximab and switch to methotrexate, they seem to respond well. As far as the CNS lymphoma is concerned, initially I would probably screen them once in a year. Initial baseline screening is done, then once in a year. As the disease probably, as years go by, then a more frequent screening may be required.
So how common we can pick the retinal infiltrates of lymphoma on OCT?
Whenever it's a primary intraocular lymphoma and the media is clear enough, I would suggest doing this OCT. So there are those classic signs of the outer retinal layer being thickened, because many times you can mistake this to be a wet age-related macular degeneration.
Yes,
you can
sir.
mistake this to be...
They resemble the drusen.
Exactly. Yeah, you can mistaken to be that. So you will find this inflammation in the vitreous and the outer retinal layer thickening. That's something which seems to be classic for a lymphoma. So I used it quite often if the media is clear enough for us to allow an OCT.
Secondly, sir, in every case, that is MRI should be done to rule out lymphoma,
Definitely,
CNS
yes.
lymphoma.
Yes, a MRI of the brain and the spine should be done.
Okay, sir. Thank you, sir.
Sir, I just want to ask a simple question. In general practice, we don't see these cases very often, right? For example, I'm stating if a person is not specifically a VR specialist, let's say a person is just practicing medical retina along with cataract surgery or something like that. So these cases might not be very common. So when this kind of a patient comes to you, usually your first diagnosis is posterior uveitis or something like that. So what are the clinical signs, or what are the things that should basically make a person suspect intraocular lymphoma in the first stage itself? Because usually a person will, if you have a heavy OPD volume, you would just regard it as a posterior uveitis and send the patient away. So what are the things that should basically light a bulb in your head that this might be something else other than posterior uveitis?
Agreed. Yeah, one is the age group. So usually about 50-60 years of age is one. Bilateral uveitis you have, including the vitreous inflammation, as well as you would find the retinal or choroidal. There is no choroidal inflammation in the sense like what we look at primary intraocular lymphoma. You will find a vitreous inflammation and some retinal infiltrates. So these are what it can be. So, like basic investigations we do to rule out tuberculosis as well as sarcoidosis, those are things which we rule out, despite which if the patient continues to be there, sometimes it could be after a therapeutic trial, you treat the patient with steroids, and these patients are resistant. They get better, then you start tapering the steroids, they have like recurrence of inflammation. So even if you don't have the initial time suspicion, when the patient keeps recurring or recalcitrant disease, then you need to think that whether you're looking at a lymphoma. And one of the things is, as I mentioned, the OCT. So OCT, when you do these signs, what I showed, if you find them, then once again suspect a lymphoma.
And uveitic profile you would have done already for the patient. And so the first thing when you suspect is go for a contrast MRI straight away?
Not necessary, as I mentioned. So if in case it fits into this category, a bilateral uveitis which is not fitting into your usual uveitis profile, then is when I would think of doing an MRI, because only about like 20% of the patients may have the CNS lymphoma when they present to you. So 80% will not have; they will develop subsequently. So you doing an MRI initially may not be diagnostic. We need to suspect a primary intraocular lymphoma and prove it by doing a vitreous biopsy, and only then you would probably think of doing an MRI.
Last thing, sir, for the panel before the session closes, regarding the second talk on wet CNV, if you could comment on the real life results of Paganex versus Eylea in your chronic resistant cases. If you could provide some insights into that, that would be helpful. Before the session closes, of course, after the talk.
Sure. We'll do that at the wind-up. I think Dr. Gupta has standing here for a question on this talk.
I wanted to know, you had a very good pathology backup, and I can't find a very good pathology backup. So do you send it somewhere, or do you recommend any chain where you can get this kind of diagnosis?
Earlier we didn't have an in-house pathologist. We have been having an in-house pathologist for the last 6 months only. Earlier we used to send to this Anand Labs, which is there in Bangalore. So the key is to take a good specimen, stop the steroids and transport it as early as possible, and then speak to the pathologist and send it across to them. So despite which many times you may land up to be negative. And if it's a cell block which is prepared, then I would send it to an established center like Shankar Nethralaya. So I would usually send it for a second opinion. Once a cell block is prepared, this specimen can be stored and like another opinion can be taken. So I would usually send it to Shankar Nethralaya for another opinion, and in addition to doing a local pathology.
And any chain you can recommend where we can send it? There are multiple chains available.
You can, as I mentioned, like if you have prepared a cell block or slides are there, you can send it to Shankar Nethralaya, Dr. Krishna Kumar for another opinion. I'm sure he tells you.
Thank you, sir.
Last question, I think if any patient who develops about the muscaride, any patient who develops the uveitis first time after 50 years of age, I think one should always think of the muscaride disease.
I would agree.
Anybody after 50. So second question, can we do supposing if you don't want to do the extensive for PIOL, intraocular lymphoma, can we just do the vitreous tap in the OPD? Not the biopsy, I'm not saying the full biopsy.
I would not be comfortable because like there is a risk of little detachment because of sucking the vitreous out. So it's better to use a vitreous cutter and take a biopsy rather than using a needle.
You don't want to take him to the OT and all and do the OPD.
I would be comfortable using a vitreous cutter to take a biopsy.
I think, sir, since we are dealing with a potentially life-threatening condition, it's probably best done in a theatre setting where everything else is controlled. And the other question for someone in general practice, I think if there's something that doesn't fit, just send it to someone else, take another opinion, and if both of you feel it doesn't fit, then we send it to a third person. Your question was on faricimab or Paganex in resistant CNV. Yeah, I think it's a question of resistance versus comfort level versus explaining to the patient there's a remote risk of inflammation with any of the new anti-VEGFs. So I think ultimately one would have to take a call. Has the drug been given in the protocol that it was intended to be given? Is the follow-up good? Have you actually seen the way it's responding before you decide to switch? Sometimes switching happens too early and then you really don't know what works. So I think we've had a very interesting session for those of you who were here the whole time. A lot of new things that all of us have learned. I'd just like to sum it up because we have one less speaker, so we are finishing a little ahead of time. Does anyone else, before I sum up, have any questions or comments on any of the talks? Yeah. Okay, so our first talk was by Dr. Tara Prasad Das, who had to go for another session, who spoke on the challenges in handling and diagnosing retinal diseases in India, basically the challenge of accessibility for examination. And the second was a pre-recorded talk by a Chinese ophthalmologist on red light therapy in myopia, the hazards of low red light therapy. And that was, I think, an eye-opener for all of us, at least in India, where we have probably just read about it, not seen it. Possibly temporary effect, but also a little warning sign of potential retinal problems due to red light exposure. And the third talk, real-world studies versus RCT in the management of neovascular AMD. I think what stood out was the long gap to recurrence, sometimes even 6 to 7 years, indicating that you have to follow up these patients well. There's a role of OCTA, but also a role of ICG as well as focal treatment. And Dr. Timothy, I think a diagnosis of OCTA in an otherwise, of CNV in an otherwise quiet eye, you find things you're not sure what to do about, because when you see a CNVM in a normal eye, and then, but what we know is it can progress slowly, and you need to follow up the patients. Probably a little shorter follow-up for patients where it's the only seeing eye. And then again, a very interesting talk on adaptive optics in albinism. Many of us have had this experience. You see a patient where the fundus looks albinotic, the OCT is fine, vision is poor, and now we know that it may be just an impaired circuitry. And adaptive optics is an exciting new development to try and understand why these patients are not seeing what we think they should. And then the last talk, real eye-opener by Mahesh on masqueraders. I think the take-home point is extremes of age, something that doesn't quite fit, and recurrences of problems despite what appears to be adequate treatment should always be a red flag, and you need to look at life-threatening problems like malignancy and also infections, which can just look like inflammation. So thank you to my co-chairs, Dr. Shruti and Timothy, and thank you all for joining us this morning. With this, we wind up the session. Can we have a photograph with the speakers, please?